Greetings, everyone. A very warm welcome and thank you for joining us for the second day of the Align M&H Collective. I hope you were able to join yesterday's session on tracking progress for maternal and newborn health action, what data, where and how. My name is Sham Saeed and I'm the unit head for quality of care at WHO, and I am delighted and privileged to be moderating this lively and dynamic regional dialogue on respectful care today. First, a bit of housekeeping. We will be active on social media throughout the proceedings and welcome you to engage. The April collective hashtags are hashtag April22 collective and hashtag road to 2023. You will notice that we have simultaneous translation occurring from English to French. And if you wish to hear the session in French, please click the link below the video player on this page. And we encourage you to use the chat function for comments, questions throughout the session. And it's located immediately to the right of your video player. And you can use it to type in any question you may have for speakers. If you have any technical questions or need support, please click on the red circular word bubble in the bottom right of your screen to open the hashtag help chat and access support from the technical team. We'll be using various interactive tools throughout the live sessions and encourage your participation. When a prompt becomes available, you will see a note in the chat directing you to scroll down the page you are currently on to view and respond. And when the tool is active, use your mouse and keyboard to respond to the prompt directly in the box in which it appears. The tools will update in real time as you and your fellow participants interact with them. So let's get started with that. If we have a poll you can complete now indicating where you are joining today's session from. Simply scroll down on the same session page and click the plus button and enter in your information to participate. It would be wonderful to see where all colleagues are joining from. Now, to open our session, we are delighted to hear from Melissa Jones, Deputy Assistant Administrator for the Bureau for Global Health at USAID, who will offer some remarks on the importance of respectful care for women, newborns, and families. And then we will listen to a brief presentation by my dear colleague, Dr. Rozge Tonkalp, of the Department of Reproductive Health and Research at WHO, who will set the stage for today's moderated dialogue. Really looking forward to this.
Thank you, Dr. Saeed, for that warm welcome. I would like to extend my sincere gratitude to the Align M&H Steering Committee and our long-standing partners at the Bill and Melinda Gates Foundation for inviting me to speak to you all today about the importance of quality, respectful care for mothers and newborns. You know, throughout my career in the Foreign Service, I have had the opportunity to see firsthand how safeguarding the well-being and dignity of all women, families, and communities is foundational for achieving a healthy and prosperous society. As contributors to locally led development and partner country leadership, we at USAID want to do all that we can to advocate for increased transparency, good governance, and sufficient domestic resources to tackle these health challenges. My work in countries in Asia and Africa remind me of the simple truth behind what brought us all together today, and that is every woman, newborn and child, has the right to the highest standard of care, including the right to dignified, respectful, and quality care, no matter where they live. But we also know that this right is not always upheld. Too many women continue to face disrespect, mistreatment, and even abuse before, during, and after pregnancy and childbirth. These harmful experiences negatively impact their physical and mental health, as well as the health and well-being of their newborns. In response, USAID invested in groundbreaking research in Kenya and Tanzania to uncover the magnitude of the issues and the circumstances that perpetuates it. We at USAID recognizes that each country's context is unique and needs a broad understanding to design effective solutions. So we later partnered with WHO to expand this body of evidence in Ghana, Guinea, Burma, and Nigeria. These efforts include launching of the Respectful Maternity Care Toolkit for clinicians, educators, and supervisors of clinicians. But unfortunately, the COVID-19 pandemic has pushed many women and newborns further from the qualities and respectful care they need and deserve. The pandemic, especially in the early months, limited antenatal and postnatal care visits, emergency obstetric and newborn care services, and facility-based labor and delivery. As a result, maternal deaths in stillborns have increased, and pregnant women continue to navigate fear and uncertainty in the wake of COVID. Sadly, these factors will impact health systems and health-seeking behaviors for years to come. And as we rebuild the health systems, we cannot approach care as it was before the pandemic. We must commit to do better. For decades, global health has largely been focused on improving access to care. However, evidence now shows that poor quality of care is responsible for a greater number of deaths than insufficient access or no care. So moving forward, we must design care with 4 critical components in mind. First, elevate the voices of women and families. Second, address the social, structural, and environmental determinants that impact health outcomes to support overall system change and reduce inequities. Third, recognize that access to healthcare alone is not sufficient to reduce mortality. And lastly, strengthen health systems by engaging and listening to all involved, decision makers, researchers, health workers, women, and communities for a whole of society approach to health and well-being. You know, USAID, along with all of you, are committed to making global health and development assistance more effective and sustainable by empowering local actors, strengthening local systems, and facilitating local leadership. We look to many of you to lead in this effort. As I close, I'm looking forward to learning more from this diverse and vibrant community and the ongoing dedication shown to improving maternal and newborn health. These conversations are a great start, and I look forward to our collective actions to support mothers and newborns. I want to thank you all.
Hello, everyone. My name is Özge Tunçak from WHO, and as thought partners with Align MNH on the Respectful Care track, it is my great pleasure to highlight some of WHO's recent and ongoing work in this area and to set the stage for the regional dialogue. First, I would like to start by mentioning terminology, as you will see different terms used to describe this phenomenon. The first document WHO published on this issue was the Statement on Prevention and Elimination of Disrespect and Abuse in 2014. And following this, a mixed method systematic review was conducted, and based on the evidence, we started to use mistreatment and the associated typology. Moving on, we conducted a similar review for better understanding respectful care, and now in many of our research norms and standards documents, we use mistreatment and or respectful care depending on the context. Based on the typology that emerged for mistreatment, we conducted a multi-phase, multi-country study to develop and test 2 tools for measurement, one for labor observation and one for community. And across 4 countries, these tools allowed us to better understand how women were treated, and our results were telling in terms of the extent of physical and verbal abuse, which were more likely to occur within 15 minutes right before birth, high levels of unconsented procedures, and the fact that younger women with less education were more likely to experience this. We need to keep building the evidence base, and we need to keep understanding better. For example, what about newborn perspective? Based on this research, we looked at 1,618 maternal newborn dyads, and we observed 15 practices for newborns. And these were more related to places where actions can be taken immediately, especially around improving uptake of recommended practices. And we highlight in this analysis that further research is needed because we need to better understand women's and families' expectations and preferences, and also what practices might constitute mistreatment and respectful care for newborns. The other thing that we did, and this is actually an announcement that at the end of March, a new special supplement was published on understanding mistreatment to improve quality of care during facility-based birth. And this new supplement looks at 6 analyses, and it includes evidence on labor companions, satisfaction with care, looking closely to vaginal examinations, adolescents, and shortened measures for labor observation and community tools, which you can access from this link. A couple of things that I want to highlight. And one of them is that respectful care is a human right. And engaging women and accounting for their experiences in health systems is the first order of respect in a human rights approach to maternal and newborn care. And we've been seeing this at the work of high-level bodies like the UN Rapporteur for Violence Against Women and also the Parliamentary Assembly of Council of Europe, which highlighted these issues and put recommendations forward for countries and nations at the highest levels to introduce new policies and laws. The other thing that I want to highlight here is that good quality care is safe and respectful. And you could see it in the standards for improving quality of care that WHO has been producing, applying the same framework for quality of care, which includes both provision of care and experience of care within a health systems approach, looking at maternal and newborn care, which was published in 2016, followed by children and young adolescents in health facilities, and more recently in 2020 for small and sick newborns. What are some other mechanisms that evidence on this issue can inform practices at the facility level to enable respectful care? One such mechanism is the WHO guidelines, which incorporate person-centered respectful care within the recommendations. And first, it was in 2016 with the publication of the antenatal care recommendations for positive pregnancy experience, which started with the review, which asked the question, what matters to women during this period? We've followed it up with the intrapartum care recommendations in 2018, and there's a recent addition to enable implementation of these recommendations, which is the new WHO Labor Care Guide, operationalizing next generation cartograph to be used by healthcare providers. And this incorporates the new recommendations, including experience of care. And more recently, another just launched product that I'd like to highlight here is the new postnatal care guide. Again, taking a similar approach to ensure respectful care across the continuum. And this guideline, just launched at the end of March, includes 63 recommendations across maternal care, newborn care, and health systems and health promotion interventions. And they address individual interventions for care, but also service delivery arrangements and requirements for competent and motivated providers. And you can access the full guideline from the link on this slide. The other thing that I want to mention is the quality improvement processes and quality improvements, and how do we integrate respectful care within maternal and newborn PI programs. And one example is the Quality of Care Network, which is a broad partnership of committed governments, implementation partners, and funding agencies working together to reduce maternal and newborn mortality and stillbirths, and also improve experience of care. And there's a lot of learning that's been going on in terms of how do we include women-reported experiences during childbirth within quality improvement initiatives? How do we learn in terms of measuring experiences through tracer indicators within health systems? And how do we do caring for carers, especially with a focus on midwives? And within this work, we have been also looking at connecting with other movements like the compassionate care and within health systems. One final thing that I want to mention is for strategies to reduce mistreatment and improve respectful care, we need to take into account certain things that are beyond service delivery, that are about system and society, where we need to challenge harmful and gender stereotypes, work towards eliminating intersectional discrimination, disrupt power dynamics, and address health system conditions and constraints. And with many of the experts in this field, we have been working on 5 reviews to be launched in 2022, addressing drivers of mistreatment of women and looking at evidence from cross-disciplinary literature, which we hope will inform the WHO HRT knowledge translation toolkit to inform country and support country and the stakeholder activities to really make this a reality. And trying to identify and find solutions and show us how to move forward and make respectful maternal and newborn care a reality in the field. We have an excellent panel of speakers from Lebanon, Pakistan, Afghanistan, India, and Canada exploring strategies to move respectful care into practice, drawing on evidence and country experiences. They will be reflecting and guiding us on what is needed to ensure that respectful maternal and newborn care becomes a reality for all.
Greetings all. Delighted and honoured to moderate this important dialogue on respectful maternal and newborn care. We have a depth and breadth of experience and wisdom within the panel today. Just to give you a frame of how we'll take this, I'll be posing some questions to each of our panelists, and we look forward to some lively and perhaps even provocative responses from each of the panelists. Our focus is certainly on authentic dialogue and actionability that follows from the dialogue. So let's get started with the first question. Different roads have led countries to reflect respectful maternal and newborn care as a core component of quality maternal and newborn care. What are the different approaches to policies related to respectful care in the region? And could you tell us more about the benefits and challenges of these different approaches? I'll be turning to Ms. Bhavya Reddy to give us her thoughts on this, and then to Dr. Amanullah Khan. Ms. Reddy.
Thank you, Shams. It's so great to be here, and so excited to get this conversation started. There are a few interventions approaches by the Indian government that are worth mentioning that address the problem in both direct and indirect ways. So the first is improvements to medical education. We know from our own work and broader understanding that medical students in India are not formally trained in any structured way on how to treat patients. So they don't even have a benchmark for what ideal behavior should be. In 2018, also the Medical Council of India introduced a module on attitudes, ethics, and communication, which runs through all 4 years of undergraduate education. And so the concepts they cover are very relevant to RMC. They include things like effective communication, autonomy in decision-making, confidentiality, etc. And it also looks at, sort of investing in the patient-provider relationship. It introduces students to a human rights framework. It's got some content on healthcare as a right, being cognizant of socioeconomic inequalities. So all of this is a really welcome change to what exists in medical education. And we hope it'll have downstream effects on provider behavior. But it is sort of a missed opportunity to link these efforts to RMC respectful care. There's no mention of intrapartum care in the content, though we know the second stage of labor is particularly where communication breaks down. And it's also not adequately contextualized within health system realities, the constraints and pressures. So the gap between what students will learn and the reality of their practice environments are going to make it very difficult to apply. Depending on time, I covered maybe 2 other approaches. The other one is the expansion and professionalization of midwifery in India. I know Kaveri will have more to talk on this, but we hope with the introduction of nurse practitioner midwives in India, then going through longer, more rigorous midwifery training than we previously had, that we will see more women-centered care as well as more rational care with fewer unnecessary interventions. But the Ministry of Health has chosen to place these trained midwives in secondary and tertiary institutions to manage higher caseloads. And while we understand that, we also know that these higher level facilities have very entrenched medical and professional hierarchies, and empowering newly trained midwives to exercise their full scope of practice in those settings is going to be challenging. Because we're not seeing adequate preparation in facilities or with doctors and with professional bodies for their entry. And the third I will try to very quickly cover is a labor room quality improvement initiative. It is an accreditation process that helps facilities to meet standards on infrastructure and equipment and human resources, specifically in labor rooms and OTs. It includes a lot of aspects of RMC, which would be assessed based on facility observations and observations of staff behaviors. And the idea is that facilities that meet 70% of those markers will get the accreditation. So we, in the state of Karnataka in India, we're already seeing infrastructure being upgraded, facilities being spruced up. But we expect that facilities will tend to meet these thresholds and get accredited based on making those structural changes to the environment. So putting in privacy screens, playing ambient music, and the tougher task of modifying attitudes and behaviors won't get picked up easily. So these are some of the approaches that that come to mind, and I thought were worth mentioning here.
That's fantastic, Bhavya. Thank you for starting us off. Same question to Dr. Aminullah.
Okay, thank you, Shams. I think in Pakistan, the health service provision is regulated and the quality of care is ensured by the healthcare commissions, which have been established at the provincial level. And White Ribbon Alliance Pakistan worked with the healthcare commissions of Punjab and Khyber Pakhtunkhwa provinces. The purpose was to support the healthcare commissions in development of minimum service delivery standards. This all started with the formative research which was conducted by White Ribbon Alliance Pakistan on to assess the level of abuse with regard to respectful maternal newborn care in Pakistan. And the results were really very frightening because the abuse was not confined to only verbal abuse, but there was like physical abuse as well, which was reported or quoted by the women who responded to those questions. So once we had that evidence in our hand, we took it to the healthcare commissions, and they and also kind of disseminated with the wider audience as well. And the healthcare commissions very kind of agreed to incorporate the standards related to respectful maternal newborn care within the minimum service delivery standards. So we provided them with the technical assistance to get that into the integrated into those standards. And then once the issue was that how would these standards be kind of institutionalized or put into practice, for that we engaged the professional associations in Pakistan, like the Society of Obstetricians and Gynecologists in Pakistan, Pakistan Pediatric Association, and we kind of shared the findings of the formative research with them, and also the draft of the minimum service delivery standards for their review and also for their adaptations. So that process was taken, their voices were added to our voices, and that was kind of made a joint effort on part of the partners and also the healthcare commissions. So in that way, we were able to successfully get these maternal newborn care, respectful maternal newborn care standards within the minimum service delivery standards of the healthcare commission. So the lessons learned, which I would summarize here, is that it's important to have some national level evidence in hand once we are kind of talking to the policymakers or the decision makers at the country level, because they always value the local evidence, although a lot of global and regional evidence is available, which could complement that, but having a national evidence is important. And then it's important to provide some technical assistance at the right time with the right kind of persons to the government, because the government usually are not very proactive with regard to the development of such tools or standards and systems. So we provided that, and that also helped. And third important lessons learned or for us was that to have more partners involved and engaged so that it becomes the shared objective of all of us, which we did with the professional associations and which helped us in facilitating that process and getting it integrated into the standards. The challenge remains that how would these standards be monitored, for example, and how those actions will be taken against the non-compliance of these standards. Well, the mandate, although remains with the healthcare commissions, but I think some consistent advocacy and some consistent support is required to make sure that those standards are complied with by the healthcare providers, and also there is a raised awareness at the community level. So what we did, another effort which we did was to in that direction was that we developed some protocols which were developed which were displayed in the labor rooms of the hospitals and also health centers. So this kind of kept on reminding the healthcare providers about their responsibility and also informed the patients and the mothers who were coming to those labor rooms so that they kind of considered it as their right. So this was an approach which was adopted, and this was some of the challenges which we faced, and that I think needs to be taken into consideration. Thank you.
Wonderful, Dr. Aminullah. And so we've heard very clear, tangible examples and practical experiences from India and Pakistan, which have wider ramifications. Let's turn to the second question, which is a challenging one. And it's related to broader issues around quality of care and how they're addressed, along with RMNCA interventions. So this commonly comes up. Many of our colleagues in the MNH community often wonder how we can work towards improved RMNC, even when other important aspects of high quality care are lacking. For example, without enough supplies, despite workforce shortages, how can we continue to prioritize RMNC? I'm going to turn to Dr. Tamar Kabakian and then Ms. Fahmi Naziri, and then coming back to Bhavya for any quick points. Dr. Tamar.
Thank you. This is, as you said, an important question, and we're going to start from the beginning, from where this move towards facility-based births happened for all women in all countries. And it was, the time when the health system deficiencies were exposed. So many facilities face difficulties in resources. These are significant shortages in staff and other resources. And some also, on top of that, have high flow of service users. So all of these have already been identified in the literature as drivers of disrespect and abuse during childbirth. So it becomes necessary with this background to not only view respectful care as an essential component of quality of care, but also apply it. And I think we all definitely define it like that and widely recognize it as a core component of quality of care. However, it's not easily translated into practice. And at least in the part in the global part in the region where I come from, in the MENA region, the technical aspects of the care are usually take precedence over the experience side of the care. And we see in resource constrained settings, especially, a lot of emphasis put on advancement of technology or adoption of technology, which is equated with quality. And this adoption of technology is not always based on critical assessment of need. So this becomes really important issue to consider in settings with limited resources. So how do we view quality, and how do we assess and measure and perceive quality? In these settings also, it is particularly important to consider the provider level mechanisms that contribute to this respect. We know that weak health systems don't offer much to providers, whether that's in terms of remuneration, professional development, or otherwise. And healthcare providers in these settings work in disrespectful or unsound conditions, and this is more of an acute problem among midwives and nurses, who are the main carers during childbirth. And this can definitely lead to an atmosphere where you have disrespect and abuse normalized, you have disrespect and abuse between providers themselves, and that trickles down to how women are treated and has its impact on women's experiences. with the care that they receive during childbirth. So to address RMNC, as well as to reduce mistreatment and abuse, and we know these are, the opposite sides of the spectrum, I think we need to put more effort into addressing cultural competence within its context. And this is something that is highly contextual, and it needs to be defined in its own context. It needs to be operationalized and introduced, context-specific manner. We know that we need multi-component comprehensive approaches, and one of the important attributes of such approach is the development of context-specific solutions and interventions. Therefore, an in-depth understanding of the context is needed, and this needs to guide us to context-specific practices and policies. And here, I want to emphasize on context-specific because we very much focus on limitations of the settings, but we do not understand the assets of the settings. So how can we actually capitalize on the assets in resource-constrained settings to move the RMNC agenda in those settings becomes an important question today. And this actually needs to happen in parallel with, continuous efforts for strengthening weak systems, continuously advocating for incorporation of RMNC as component of quality of care in all policies that are reflected for maternal and newborn health. Thank you.
Wonderfully put and so nicely summarized, Dr. Tamar. Can I turn to Ms. Fahima Naziri? Fahima?
Yeah, thank you. Although the challenges and barriers of quality of care and respectful maternity care are the same in many countries, but some countries has their own challenges. For example, if I give you an example from Afghanistan, 4 years ago or 6 years ago, we didn't have higher education for midwifery. Besides this, we did not have a regulatory body to ensure about the quality of midwives work and also ensure about the quality of educational system. Although we didn't have the political support, the government leadership support, these were many challenges. We as a professional association did a lot of advocacy many years to build these gaps in the system. We established a newly regular education for midwifery. Recently, after the regime change in Afghanistan, everything changed. What we did service, we fought all of them stopped because here in Afghanistan there is midwives, all healthcare providers struggling a lot with regarding their shortage of supply, regarding their own economic situation, that they are not receiving many salary, even they don't have money to pay for their transportation to go to a health facility. The situation, even the mothers now are not, they don't want to come to health facility because there is limitation that if they want to go to the have antenatal care or any care, they want to health facility, they should be with mahram. So same challenges and this limitation for healthcare providers as well. So it's a lot. Cannot, because of time limitation, I cannot say. But what we did in Afghanistan to ensure about this respectful maternity care and quality of care in past years, we try to reflect respectful maternity care and quality of care in the midwifery curricula, in our educational curriculum, and also as well as we try to bring changes in the midwifery job description through regulatory body. One of the things that we did, another things that we start collaboration with other professional associations. For example, we start collaboration with Afghanistan Society of obese doctors, which called AFSOC. We start with them to address these gaps of respectful maternity care and also highlight the positive behavior change how to, this should be highlighted, how to do advocacy for this. But you know, when the respectful care is something should comes from your heart. So we start to another thing, we looked for new approaches, and one of the things that we recently as a pilot started, that is the midwifery model of care, that recently we start 2 center of that. This is where we try to mothers have a different positive experience from their pregnancy and childbirth, and also this should be a good enable environment for mothers to come to the to receive the respectful maternity care and help the midwives to how to do respectful care. These are the things that we try to implement in Afghanistan to as a new approach, as a new initiative to address this respectful maternal care.
Thank you so much, Fahima, and for that clear and really authentic reflection from Afghanistan. Javier, were there any quick points that you wanted to mention on this particular question?
It's building a little bit on what Tamar had said about the treatment of nurses and midwives, but we just finished a review on organizational factors that impact provider behavior and care, and the extent to which it's really influenced by resource shortages. And we did find areas of management that are not that driven by shortages. So there are 2 areas. We see in high caseload facilities that nurses and midwives are still relegated to administrative tasks and away from direct intrapartum care. So there's a need to rationalize roles and responsibilities that will necessarily have to break professional hierarchies. There's also issues of poor supervision, both the absence of feedback and negative supervision that's not really driven by shortages. So these punitive responses to errors, creating a culture of blame is very harmful to providers psychologically, and it impairs their ability to provide care in many ways. Strengthening institutional leadership, providing supportive supervision, creating a culture of much more open communication and teamwork, and we found that this can buffer the effects of shortages on providers. So really focusing on organizational management at the institute.
Thank you for those additional points, Pavia. We're going to start to keep the pace, going to the 3rd question, and I'll be coming to Dr. Kavira Myra for this particular one, and for some additional points from Fahima. The need to support healthcare workers is another critical topic. We've already touched on that in various guises through the questions that we've been reflecting on already. The issue of providers' mental health and self-compassion really come to the forefront here, particularly in the COVID-19 pandemic. And it's key to moving forward with RMNC. Providers are often battling with sociocultural, economic, professional barriers. How can we overcome this challenge? How do we start? And what are the linkages between RMNC and compassion that can drive action for positive change at the point of care? Lots to unpack there. Dr. Kavira.
Thank you so much, Shams. We had seen during the COVID-19 pandemic the impact it had on the mental health of our healthcare providers, and particularly those at the front line. I think we often, when talk about respectful maternity care and newborn care, we tend to forget that workload related burnout kind of makes you lose compassion. And the kind of work that midwives, nurses, we do involves a lot of getting in contact with births and deaths, and a lot of sensitivity around how to manage those emotions around them. It's not really easy to switch from one birth to another, switch from one birth to death, and often keeping in mind that they are providing care to multiple people at the same time. So I think that is one of the things that I think we forget to look at healthcare providers, particularly those at the bottom of the hierarchy, in a very, very structured, deeply patriarchal kind of a rigid structure where we function. We forget that these midwives and others who are further below in the hierarchy are actually also victims of a very insensitive, I would say, healthcare policy and structure, which does not necessarily take into consideration that it can show through things like human resources for health, the ratio to maintain, the wash-related facilities, and all these things. And I often talk about this, that you can understand whether compassion is being shown or not in little things in the hospital structure, in the obstetric structure, whether you see a very good, the most functioning toilet in the medical superintendent's room and nothing which is attached to the labor unit, that says something. And who exactly is providing that care? So there are ways that compassion can be shown from a very high level. And it's also seen that it usually is kind of you can call it a ripple effect or a domino effect, where compassion and the lack of compassion begins at the center with the leadership that there is. And if you have a compassionate leader, even in regular conversation, even in signing documents, there are various ways of showing that. It kind of ripples out and kind of creates a negative environment or an environment of lack of compassion, of disrespect, of abuse, or it can begin there. So no matter what kind of day as a care provider I'm having, if I'm treated well, I will pass that on. So I will leave my points with those.
Beautifully made. Fahima, did you want to add any quick points to that from Kaveri? Please.
Yes, sure, Shams. Yeah, Afghanistan, our experience in Afghanistan with more than 40 years of conflict and war in Afghanistan, there are high burden of stress, and beside this, mental health has problem is a lot in Afghanistan, and the healthcare providers, especially midwives, are not separated from this mental health that affect everyone. Also, beside that, in the health system, we had lots of problems. Where how do you respect others when you are not respected through your system or through your you're not respected through your with your colleagues. So I think this respecting of the midwives and healthcare providers, especially midwives, are the problem of many countries. That Afghanistan also are not separate from that. But we, as a professional association, did a lot of advocacy and try to raise the midwives' voice and to address these challenges. Beside that, to how despite these all challenges, how to have a positive behavior, we try to have approaches for that. For example, we have a mentorship approach that it is we have as an experienced midwife as a positive model behavior beside the midwife, and she is working with a newly graduated midwife and train them how to work with standard, with good quality of care, and also as well as respect for maternity care. So this is an approach that AIM is implementing that a lot, and we are struggling to, it should be a SCLAP in all health facility in Afghanistan. We are doing this our Ministry of Health. But recently everything has changed and everything is stopped right now. And another point is that during COVID-19, even right now, because of what we did, we in that pandemic also the mental problem and the stress of the health, the midwives were a lot, and also they wanted to know many things about. So we try to have communication through our social media to reach the midwives, and also work with them to support them to find their challenges and bring it to the policymakers. One of the things that we did for that, it was an effort. And beside that, we, as a professional association, we try to build a strong profession to support each other to show the resilience continuing to serve the mothers despite the exist of the current challenges that we have in Afghanistan. Right now we are doing that, we are struggling, but to further, to go ahead, we need support from the international community to support us to go ahead, to support mothers, to do respectful maternity care. As before I mentioned, now the mothers doesn't want to come to the health facility. How we should go near to mother. So these are the things that what we did in Afghanistan.
Fahima, thank you so much again. And of course, we could go really into depth in your experience, and I feel awful in moving our conversation along. Time is not on our side, but we'll go to one final question. We know that we can't achieve true RMNC without active and meaningful inclusion of women, families, and communities. How can we amplify these critical voices while also ensuring that the perspectives of health workers is also represented? Is there a way to bring in all points of view and balance diverse needs? And also bringing in the measurement side, is there a way to think through measurement systems to incorporate this call for active and meaningful inclusion of women, families, and communities? So on the measurement side, I will come to Dr. Kaveri first, and then to Dr. Amanullah, and then Dr. Tamar. Kaveri?
Thank you so much. I think it's a very difficult question to answer when somebody asks you, are you respected? And I think there is a tendency to say yes. And I think we all will say that if any of us was to be asked in any given context. I think it takes a lot of courage to say that I was not respected. And that is why it's very difficult to measure this. And we often see there is a lot of quantitative studies that focus on measuring respectful care and measuring disrespect and abuse and using all kind of language that there is. And because it's mostly women who are at the front of these questions, we have a tendency of saying a bigger yes. We don't want to accept that we have been, it's gender-based, and I will not get deeper into it, but I will try to answer towards a solution. So in my work, in my PhD, I have struggled a lot in trying to find an answer of what exactly your experience is, and trying to basically bring out the disrespect, the abuse, the obstetric violence. And I have faced a lot of respect, while I have not seen that respect being delivered when somebody is giving birth or somebody is in labor. So I use something called birth mapping or body mapping, which is a visual arts-based technique, which helps bring out the embodied nature of these experiences, which are very sensitive, which are full of stigma. There's a lot of shame. There's a lot of difficulty to talk about body parts which are involved. And we have to keep in mind that we are sharing from a point of disadvantage, where women are at the bottom of the social hierarchy, and talking about the doctors or nurses or midwives, who are probably the only person in that community, right? So it's not readily somebody is going to say that, yes, I was disrespected, this is my experience. I think there is a need to give time and let people open up with their stories. And the need to do that is also to do it very respectfully. And we have to look within our systems if there is, if people actually want to know and people actually want to bring about changes. And I think we need to stop asking women and frontline care providers this for some time, and instead target people like health ministers, politicians. Who exactly is accountable? What do they understand with respectful care? What is their experience of becoming a father or a mother for the first time? How were they treated? What are their stories? If we do not move from that bottom-up approach and start finding what exactly are leaders who have the power to make these changes believe, we can't ruffle those feathers, we can't make an impact, we can't make them uncomfortable with what's going on in their states, in their countries. I think it's difficult to bring out, what the reality is on the ground through measurement. Thank you.
Very well put. Amanullah, turning to you.
Shams, I would basically give an example of White Ribbon Alliance campaign titled as What Women Want, wherein we reached to about 250,000 women across the country. it was quite a diverse group comprising of from parliamentarians to academicians and an illiterate woman at the household level. So they were all they were asked one question, that what would be their one top demand with regard to reproductive health or maternal, newborn and child health. So they came up with their demands and responses. The data was then categorized to establish their top 10 demands. And respectful maternal newborn care and family planning came out to be one of those top 10 demands. And we had an opportunity to go to pursue family planning at that point in time. And we went back to those women who responded in the campaign, and we organized what we call listening sessions. And in the listening sessions, the same women were brought together in a group of 18 to 20 women. And we wanted to dig deeper into when they say family planning, so what they specifically they mean, that the issues they are facing with regard to family planning services. So in the first session, they basically opened up and talked very openly and candidly about the issues which they were facing. And in the second session, we brought them and made them sit with the district level decision makers, and so that they can hear directly from these women. So they heard their issues, and 70% of the issues which were raised in that meeting were resolved within that one session. Only 30% of those issues were referred to the provincial level because of the additional resources required or some policy level decisions, but 70% of the issues were resolved on the ground. So a group of these women, a representative group of these women, was also taken to a provincial level meeting, so that we wanted the policymaker to hear directly from them. And it resulted in a decision which I wanted to share, was that the listening sessions as a strategy to hear voices from the women and from the communities and the beneficiaries directly to the policymakers or the decision maker was kind of acknowledged and endorsed, and it was included in the FP 2030 agenda of the government of Sindh at that point in time. So I only want to just make this point, that if this approach can work for family planning, it can also work for respectful maternal and newborn care. Thank you.
Thanks, Amarullah. Tamar, turning to you.
So I'm just going to go back to what my colleague said about the measurement and kind of emphasize that this, specific interpretations of what respect is probably important, so that we achieve an engagement at the level that we would want inclusion in the system. So how can we build inclusive systems where we are taking into consideration what people define, understand, and want to experience as respect? And I'm talking about women, communities, healthcare providers, policymakers, everyone who is engaged in that system. And this engagement, this inclusive process, people need to identify with, which is sometimes beyond the concept and the dimensions of respectful care that we have, already came up with. And they might have different interpretations, which is very much context related. I also want to point to what the world is going through these days, and the prevalence of violence around us, and whether that's through armed conflict, protracted crisis, whether economic wars, or any form of violence, which is becoming more and more prevalent. And this is, we're praising resilience. However, we need to closely identify how normalizing violence is around us, and how that is also will have more room in healthcare facilities. And unfortunately, maybe it will be normalizing even what we are, already seeing as very prevalent in the world. So directing our efforts towards the most pressing needs of the healthcare providers in those settings, in conflict-affected settings, at the most stress needs of those affected directly by conflict, and trying to, kind of desensitize them from the violence around them would be important for inclusion. Also, my final point is about finding opportunities in the system to engage women families with the healthcare providers. So instead of building vertical processes of engagement, institutionalizing the presence of the family or the support system of the women during labor and birth. We know the birth companionship. That is a way to engage. That's one of the beautiful examples where we can engage. There are plenty of opportunities during antenatal and postnatal care. So capitalizing on this would be also important, so that we don't actually only seek information and perspective, but also have them as, players in the process of care throughout the childbirth episodes.
Wonderful. Thank you, Tamar. Colleagues, time is not on our side. Thank you so much for those rich experiences. Importantly, there's a range of actionable suggestions that come from that dialogue. I think we can continue to explore further together as we continue to stretch our thinking. But thank you so much for that wonderful sharing and this dialogue in its totality. Thank you. Thank you to our panelists for that insightful and engaging discussion. We're not done yet. We are now looking to you, our audience, to help guide the rest of our discussion today. And when you registered for the event, we did ask you to give us some help with this. And from your feedback, much of which came from within the region, we chose 3 of the most popular questions. And we're now going to ask you to select which of these 3 questions you would like our panelists to answer. And I'll read the questions and you can scroll down to the bottom of the session page you are currently on to participate and vote for your top question. And our panelists will each have a chance to respond to the question that gets the most responses. So let me read the questions out. Question 1. Can you describe one powerful way in which programs, countries are ensuring accountability for the provision of respectful care? That's question 1. Question 2, can you describe one successful strategy to move towards a culture of respect and compassion at the institutional rather than individual level? That's question 2. And question 3, how can programs ensure that respectful care approaches are grounded in local country context? And so that's question 3. So audience, this is your opportunity. Do please vote. We'll take 2 to 3 minutes for the polling, and then we'll come to the top question. So we'll pause just for a couple of minutes to get those in. And please do just jump in, complete the poll by scrolling down on this session page and weighing in. We really are keen to get your direction on which question we'd like to pose to our esteemed panelists. So just another 30 seconds just to wrap this up, and we're just going to quickly tally up the numbers here. Okay, so it's question 1. And so let me just again come to this question. Can you describe one powerful way in which programs, countries are ensuring accountability for the provision of respectful care? And I'll start with Dr. Tamar. Dr. Tamar.
Thank you. So an important way to move towards more accountability in health systems would be through building mechanisms for community engagement. And this engagement should be in decision-making, in monitoring of programs and policies, as well as in their implementation and their evaluation. So the engagement of communities need to prioritize the most underprivileged groups. And you can define it socially, economically, or otherwise, depending on the context. And this is necessary for not only building bottom-up approaches, which we know are more, the evidence-based ways to go, but also, and most importantly, to eliminate inequities. And we can take the example of inequities based on payment modalities in health systems. And this can be a powerful way to ensure that respectful care is not regarded as a luxury, which is only available on a pay-for-service basis. And it can also enhance what is called financial accountability in health systems. Thank you.
Thanks, very clear and to the point. If I could turn to Dr. Aminullah Khan, and then I'll come to Dr. Kaveri. So Dr. Aminullah.
Thank you, Shams. I think to me, the accountability towards respectful maternal newborn care at the country level could be ensured if these respectful care protocols get integrated into national level service delivery standards by the health regulatory bodies, because it helps in institutionalization of these protocols into the systems. Two, it also helps like ensuring the accountability, because then it becomes mandatory for these regulatory bodies to track and monitor the implementation of these protocols within as a part of the overall standards and package. And thirdly, it also increases the chances, once it becomes part of the standards, then there is every likelihood that these protocols get integrated into the in-service and pre-service training curricula of the healthcare providers. So to me, I think that's the key if we have to ensure accountability of respectful care within the systems in a region or in a country. Thank you.
Great, Dr. Aminullah. Turning to Dr. Kaveri for your take, and then we'll come to Ms. Fahimi. Dr. Kaveri.
Thank you so much. I think it is very important that we find innovative, sensitive, sensible ways to listen to women and other people who give birth, who are seeking care for their various maternal, reproductive, and sexual health care needs. And this is important by not just listening to them, but also at some levels in the hierarchical system of healthcare provision that we have. We need to mute ourselves who are on the top tiers, and we need to find ways to unmute those we don't listen to, those who are the main stakeholders of care receiving. So we can actually provide that compassionate care through interprofessional collaboration, through finding ways to abolish systems that don't work, to see if there are ways we can reshape, restructure, rethink, take a step back, and provide care that is truly respectful, equitable, that is, like others have said, not thought of a luxury, but to really provide care which women and people find pleasurable. Thank you so much.
Thanks, Dr. Kaveri. We really need to look at that mute, unmute button for sure, no doubt. Ms. Fahimi, if we can turn to you, and then finally to Ms. Palva.
Thank you for prioritizing this issue. According to current Afghanistan context, ensuring about accountability is a big challenge. But as a professional association, what we would like to, well, we push to improve accountability in all level of the health system. What we would like to see for accountability and respect for care is a functional and transparent forum.
Just having a few issues in the audio. So perhaps we can go to Ms. Pavia, and then we'll return if we can get back to Ms. Fahima. So Ms. Pavia, ready, please.
Thanks, Shams. When it comes to routine intrapartum care, accountability is largely focused on outcomes and the outcome of survival in the public sector, at least, with much less attention paid to process. So this means that if mistreatment is a process engaged in to ensure the outcome of survival, it will be implicitly condoned or accepted as collateral damage by providers and institutions. So we find that questions around process and respectful care or mistreatment is a type of process. Those only come into the picture when the outcome is bad. And frontline providers in public institutions are not only coping with immense workloads, they're also functioning with a great deal of anxiety and fear about being blamed for bad clinical outcomes. So, there is some tension around competing health system priorities now. We also have to recognize that at the heart of accountability is power. If we simply slap on respectful care to the list of goals health systems have to now track without interrogating power inequalities, then we won't be enabling a culture of respect. It will be an added burden for frontline providers and another area to penalize them. And these deep-rooted biases against marginalized women will remain even if providers try to model better behavior. So making respectful care a very important element of accountability means moving away from just pure and sort of, the most basic clinical outcomes and making sure we interrogate power across key relationships.
Thanks very much, Bhavya. And let's just see if we can perhaps go back to Fahima. Can you hear us? And we'd love to hear your perspective.
Yes, sorry, Dr. Shams, just the net cut. As I said, according to Afghanistan current context, it is big challenge to have ensure about accountability. What we would like to see as a professional association, there should be a transparent and functional forum or system for accountability and respectful care with more community engagement as well as other stakeholders like MOPH, professional association, regulatory bodies, NGOs, and also women community, which is very important. And also recently in Afghanistan, the trust has been dropped and many works needed to build this confidence. An approach which reflects decentralization and greater social accountability is urgently needed. Fortunately, Afghanistan has a rich history of community council, which is called Shura. This Shura often has women members as well, and they discuss particular issues. One of them is health issues. They can help us to raise awareness and also about respectful care and have the woman's voice with us.
Thank you, Fahima, for that. And I'm really glad that we were able to hear those points from you. A sincere thanks to all our panelists for being here today and providing this thoughtful and important dialogue. Time is, as always, an issue for us, but we view this as an ongoing conversation, and we'll look forward to continuing to explore these issues as we move together at the International Maternal Newborn Health Conference in May 2023. So just a couple of points. The related resources for today's session can be found on the resource tab of the platform you're currently on. And as we value your opinion, of course, always we'll have some form of feedback to improve this for the future. And there's a brief 5-question survey that will appear on the session page. And please scroll down and complete that survey if at all possible. And we would really seek your thoughts on this. So we've got a few minutes left, and we would like to close today's dialogue with one final message from each of our panelists. And in a few words, what is the top priority to move RMNC into practice? There have been so many perspectives that you've provided within the dialogue today, but if you wanted to hit one point for folks to walk away with, what would that be? And I'll start with Bhavya and then come to Fahima. So Bhavya, please.
There is no silver bullet. Providers have to be trained in how to treat women. Those behaviors need to be reinforced through supportive supervision and consistent role models in their institutional settings. But fundamentally, like I said earlier, you cannot enable respectful care without an analysis of power. And we have to interrogate power in the relationships that providers have with their management and between different professional groups. If we try to create more fairness and equalize power in these relationships, if we make providers feel more supported and heard, it will be less likely that they will want to exert that power over women in ways that manifest as mistreatment.
Thank you, Bhavya. Very clear message. Interrogate power. Fahima, let's hope that the audio remains for us, and we'd love to hear your take home. Fahima? Okay, we're going to persevere with Fahima and come back to her if at all possible. But let's turn to Kaveri and then turning to Dr. Aminullah. Dr. Kaveri.
Thank you so much. I think the way health systems function on prioritizing what is important is by increasing investment. I think if funding increases to understand what is going on in terms of respectful care, in terms of the power dynamics that need to be studied, in terms of the interprofessional respectful communication, in terms of even finding ways to measure respectful care and respectful communication and everything around it, is usually seen in terms of more funding around it. So I think that is one of the main things I will focus on. I think we desperately need to invest on these issues that really matter, and that's how we show that they matter. Thank you.
That is great. That is great. Invest. I'm trying to find one word to capture each of your interventions, and I'm really pleased that Fahima is back. Can I just check, Fahima? I'm hoping. Fahima, can you hear us? Okay, we're still...
Yeah, thank you, Dr. Shams.
Yes.
Remark would...
Yes, Fahima, we can't hear you. Okay, we're going to persevere because I really would love to hear from Fahima, but if that's okay, let's turn to Dr. Aminullah for his thoughts, please. Dr. Aminullah.
Thanks, Shams. I guess pursuing evidence-based, comprehensive, and a consistent advocacy strategy or advocacy pathway in partnership with all the development partners and professional associations and communities for translating, for influencing national level policies and putting them into practice is the key, I guess.
Clear, and really focusing in on that evidence piece, not just on the actual care that's provided, but even the evidence on advocacy, communications, and movements. So great point. Dr. Tamar, please.
Thank you. So I believe that we need to work on both ends. Promoting respectful maternal and newborn care, while also in parallel working to reduce mistreatment and abuse. So we need to design, implement, and evaluate approaches, as we said, for the local context. And these local solutions may not be transferable from one place to the other, but there is knowledge generated about the how, and our continuous contribution to that knowledge of the how is really necessary at this stage. Thank you.
Thank you, Dr. Tamar. I am going to try one last time for Fahima from Afghanistan. Fahima.
Yes, sorry, Dr. Shams. Just my last remark would be midwife or the frontline provider of maternity care in many fragile settings, ensuring they are well supported, recognized, and empowered is very important to ensure about the and it will facilitate the provision of investing in midwife by strengthening their education, regulation, and association is important.
Fahima, thank you so much. And I'm really glad that we persevered because of bringing this clear point on context and particularly fragility. So we are just coming up right to the end. So again, with a sincere thanks to everybody, and thank you for joining us today. And thank you to the panelists. We look forward to seeing you at tomorrow's session, where we'll dig deeper into the topic of quality of care, which has, of course, come up many, many times. And all of these conversations will take us on our road to 2023. Tomorrow will be a special launch event of the IMNHC as well. So just 5 words from the colleagues. Interrogate was something that came up, right? Interrogate power, invest, focus on the evidence, think through the how at all times. And the last point being made quite powerfully is the context of fragility. We cannot afford to lose sight of the context of fragility, conflict, vulnerability. With that, time is over. Thank you again to the panelists. Thank you again to all the attendees. And we hope that this will be an action-focused dialogue that can then take us forward collectively. Thank you again.